Good evening. It's nice to see so many friends here in the audience. I mean, from as far away as Argentina. Welcome, Sergio. And we're gonna talk tonight about one of my favorite instruments, the Tracy. And one of the things about the iTrace is that it has so many features that sometimes we don't even know what we don't even know about how to use it. And ours is a referral practice. I have 4 ophthalmologists in my practice, and we see people from all over the country. And usually somebody doesn't come from New Jersey because it's easy. And we're able to sort out a great number of things with the Tracy. And I'm going to show you one of those things that we're able to sort out that you may not have ever considered. And it turns out this isn't anything new. It's just kind of a new way of thinking. And these are my financial disclosures. None of them apply to this evening. And what I enjoy doing is answering questions. And I pay for my knowledge in the currency of my time. And this is my email address. And if you have a case that's more a test of character than skill, send me an email and we can work through it together. So as usual, Mrs. or Mr. somebody comes in, sent from another ophthalmologist, was a near emmetrope, wore glasses only for reading for both eyes, and absolutely insists that his vision was excellent his entire life, no problems whatsoever. Underwent uncomplicated cataract surgery by really an excellent ophthalmologist. This lady was my ophthalmologist when I was an internal medicine resident, and she's absolutely wonderful. His vision after surgery was worse than before, in fact, worse by a lot. And he says, I've seen excellent my whole life, and I had cataract surgery, now I can't see much of anything. And the surgeon told the patient, you know what, the IOL's defective. So we're gonna send you to that Dr. Hill guy, and he'll do an exchange and everything will be fine. And so they put in a 20 diopter aspheric lens that adds negative spherical aberration, just as they should, placed in the eye. There's the refraction, looks like she got it just right. And of course, the vision's terrible. It's worse even at night. I can't see a thing at night. And lens capsule, lens placement, ocular surface, it all looks perfect. I mean, it was very nice surgery, as you would expect. Patient is angry. In fact, if you've ever thrown a cat in a bathtub full of water, that's what this patient was like. And he had a defective lens, and he's furious. And so how do we start with something like this? Any ideas? Any hands? Where would you start? Any ideas where you would start? This is in the back. Everyone gets an iTrace. You know what? There's a big sign in my office as people walk in. Give us your insurance card. You're having an iTrace. Okay. Okay. So the first question when we see complicated patients is, where do we start? And it's really a bold strategy. I actually start by talking to the patient. I know it hasn't been done before, but the patient tells you what they have. The examination tells you where they have it, and the laboratory usually confirms. But the problem with this guy was he was so angry, we couldn't even get much past him other than he can't see. Okay. So here's just an axial topographic map. And what we see here is an asymmetric power distribution. If you look at the corneal vertex, the power above and I guess nasal is got a big hot spot there, so this guy's going to have a lot of coma. And this is actually from the atlas topographer, and this is his aberration profile. He has a lot of vertical coma and a lot of horizontal coma. And what is coma? Coma is just a form of irregular astigmatism, isn't it? But coma can be a real game killer for lots of things, and especially for a multifocal. That's not what this patient has. These are some image simulations, and when people come in and they're unhappy with their vision, one of the very first things we do is we simulate an image. And that tells the patients 2 things. Number 1, you're listening to them, and number 2, you know what's wrong. And sometimes the patients start crying. You're the first doctor that ever actually listened to me and showed me what the problem was. So one of the characteristics of coma is image displacement and duplication, and that's what this guy has. So he has a cornea that shows coma, he has image simulation that matches. That's his problem. But why could he see well his entire life? Okay, so what are my qualifications to talk to you about this sort of thing? Well, I work with industry in this area, specifically in this particular area. And on a daily basis, I see patients with multiple aberration-based problems, mainly following keratorefractive surgery. And most importantly, I have a dog named Zernike. It's very smart, a little aberrated, but very smart. Okay. Okay, so what we're going to talk about today is Zernike polynomials, Zernike coefficients, and how this works in your practice and how the iTrace can be a way to take this to the next level and understand some things that may seem like they're not understandable. So I can't show you this exact patient because he's already had surgery, but I'm going to show you another patient that's almost the bookend of this one, and we've seen quite a few of these. So here's another patient, almost exactly the same, and you can see that they have a hot spot up above and nasal. Okay, so let's take a look at the power distribution across this patient's eye. So here's the entire eye, and the coma value is very small, almost none. And there that is right there. And there the image simulation is for the entire eye, and I think you know where we're going with this. Okay, so here's the cornea. Look at the coma value for just the cornea. And coma is, you can think of it as vector. It has magnitude and direction. So there's the orientation of the coma, and there's the image simulation of the coma. That's for the cornea. This is the internal optics, so everything posterior to the front part of the eye. There's the coma. Same magnitude, different direction. Isn't that interesting? Now, those of you who are as old as I am, you may remember that there was a guy in the late 50s, early 60s named Sornsby. If you're not familiar with the man, you're familiar with his work because he's the guy that gave us the concept of emmetropization. And often short eyes have steep corneas, shallow anterior chamber depths, higher lens powers. And it turns out that the concept of emmetropization may actually work for higher order aberrations between the cornea and the lens. And that's actually what we're seeing an example of. There's the image simulation of the lens. So here's the native lens, here's the cornea, here's the whole eye. There's the lens, there's the cornea, equal magnitude, opposite direction. Isn't that interesting? And then there's the whole eye. So that's what the patient was left with. They were left with a coma unmasked of the cornea, and that's why he was all upset. And then there's his image simulation, and that's why he's so upset with his vision. So in our practice, an axial curvature topographic map is de rigueur for every single patient. It's amazing the things you can pick up, especially if you're doing toric IOLs. And the high value of the coma was offset by the lens, of course, and following cataract surgery, this was unopposed. So solutions, well, we can neutralize the coma of the cornea with an RGP lens or a scleral contact lens. And there's now a new family of soft contact lenses that are a little bit thicker. There's a material called Contimac Philcon V3 that's sometimes used for these as well, and the optometrists help us with that. So this is one way that Tracy helps us. We do a Tracy a study on every single patient we're thinking about operating on, and also for patients who come in and say, I've got a problem, I've been to 3 ophthalmologists, nobody can tell me why. And when we do a little deeper dive into what's going on, and we look at something other than just the cornea, the lens itself, we can actually get some answers. And this guy was fitted with a scleral contact lens and not happy about it, but at least he wasn't angry anymore. Thank you.